This is a case of a laparoscopic caudate lobectomy in a gentleman with Abernathy malformation for a large adenoma associated with this problem. His preoperative workup was otherwise unremarkable. He'd had a rapid increase in the size of one of his adenomas in the caudate lobe, seen here on the MRI scan, in close proximity to the shunt. Laparoscopy was achieved through a periumbilical port. 2 other 12mm ports were used, and a subxiphisternal incision was made for a liver retractor. The operation starts by taking down the ligamentum teres and continuing along to take down the falciform ligament in order to be able to retract the left lobe of the liver. The left triangular ligament here is taken down, and this dissection is continued up towards the inferior vena cava until the liver is mobile enough to place a Nathanson liver retractor. We can see here the veil of tissue overlying the enlarged caudate lobe, and the replaced left hepatic artery is seen flopping over the top. Of course, it is possible to ligate and divide the aberrant left hepatic artery, but given the abnormal anatomy here, it was dissected. It was decided to leave the hepatic artery in situ. This was then just an extra problem to have to deal with. You can see here dissection around the capsule of the liver and the caudate, dissecting up towards the base of the lesser omentum. Some large accessory vessels are prominent there. The thunderbeat was very useful for this operation, as it has both a harmonic and a bipolar activity, allowing for blood sealing as well as reasonably rapid dissection. The video is running at twice normal speed here, and some editing has occurred to minimize the length of the video. Dissection continues behind the insertion of the left hepatic vein into the cava and down along the front of the caudate lobe as it joins the left lobe of the liver in the groove for the ligamentum venosum. Further areolar tissue is taken up around the inferior vena cava. The fibrous tissue between the caudate and the left lateral section is extended along as far as possible in order to achieve a good medial margin. We can just start to see the portocabal shunt sitting below the bulk of the caudate lobe there, with a tongue of caudate lobe tissue passing around it. And here is the vision of the inferior vena cava coming into sight now. You can see the big advantage of laparoscopic surgery in this location. This would require quite a large incision and a lot of retraction to be able to get to at open surgery, and almost always is quite bloody and has the surgeon almost standing on their head at this point, leaning over trying to see what's going on. Small caudate vessels there on the cava are taken, and one causes a little annoying bleed that's fairly readily controlled with bipolar diathermy in the end. Further dissection reveals further short hepatic vessels travelling from the caudate lobe directly into the inferior vena cava, and these are taken with locking hemoclips when they're of substantial size, and the very small ones have been dealt with bipolar diathermy through the thunderbeat. You can see that the laparoscope allows the vision all the way along the length of the inferior vena cava here to be able to identify these small vessels, which are readily clipped after dissection. The caudate side is controlled with bipolar diathermy before cutting through to minimise the number of clips and avoid clip traffic. Small tributaries from the hilum to the caudate lobe are divided again with bipolar diathermy at this point. These are really feeding the adenoma, which is the obvious large expansion of the caudate lobe here. The lesser omental dissection continues, now on the undersurface of where that replaced hepatic artery was, and again larger vessels coming from the portal venous structures and the hilum are controlled. And dissected. This was the main feeding vein that we found, and possibly a small artery is torn at the back as we go round with the right angle, but it doesn't cause too much in the way of troublesome bleeding and is dealt with the bipolar. A decision had been made to leave the shunt in place, not being sure what would happen if we located the shunt, although that would have made the surgery much easier in this circumstance, as the shunt was really quite closely applied to the caudate lobe. You can see here dissecting alongside the shunt with a couple of small tributaries running to the caudate lobe from the shunt itself. These are taken with bipolar diathermy and cut using the harmonic part of the thunderbeat. A lot of blunt dissection was used in this operation to develop tissue planes rather than what is often the case in liver surgery, which is parenchymal destruction. The surgery is being performed using an Olympus three-dimensional laparoscope with glasses that give a three-dimensional type view. It's a very comfortable way of observing what's going on, and in some ways may help with the dissection and recognition of structures, and certainly helps with suturing and a feeling of depth perception that can only be gained through 3D imaging. The other advantage of the three-dimensional scope for this type of an operation is that it does have a great deal of flexibility once it's inside the abdomen. It can turn around almost to 90 degrees, allowing the camera to be sort of placed out of the way of the instruments and yet give a great view. Further dissection along the inferior vena cava is happening at this point. there'll usually be 2 or 3 substantial tributaries to the inferior vena cava coming from the caudate lobe directly that will need to be formally ligated, as you can see in this picture. Inferior vena cava is then dissected off the back of the caudate lobe there. Trying to get around the bridge of caudate tissue that runs over the front of the shunt down to the inferior vena cava. We passed a tape from behind in an attempt to see it from the front here, but ultimately we're not successful in that. Further dissection from the front to get down towards the vena cava. Another small branch from the shunt to the caudate lobe is taken down to elongate the shunt, and now some tape is placed anteriorly to see whether we can see that from the posterior aspect. The previous tapes popped out and further dissection continues. It helps us to see how far we have to go. You can see that there's a little window of areolar tissue developing just to the left of where the thunderbeat is, just into that tissue there, and as we take that down we see the tape. So we know that the shunt is below that point now. The tape can be now used for traction. I elected not to rush to divide the bridge of tissue here, as one would expect some ooze and bleed from that, and we'll come to divide it later on rather than early on in the operation. So further dissection up near the hilum is undertaken to fully control the inflow to the caudate and peel the caudate lobe away from portohepatus structures, which are obviously vital to the remnant liver. It's a laborious process, trying to find the right plane and staying outside of the parenchyma of the caudate and the left lobe of the liver. A small bleeder from the back of the hepatic artery is identified. And has obviously been pulled on while we're trying to preserve the main left hepatic artery, which we were successful in doing. We're now really dissecting into the bridge of liver tissue as the caudate crosses over to the main liver in front of and even to the right hand side of the inferior vena cava now. And this is to ensure that we get an adequate margin when we come formally through the parenchyma of the caudate here. Another small bleeder, this time a venous bleeder, occurs, and it seems safer just to pack that off and control it with a Raytec for a while and come back to it later on. That certainly controls the bleeding very straightforwardly. You can see now the caudate lobe is essentially ischemic. It's changed in colour. It's got a very pale colour now, indicating that the blood has run out of the caudate lobe altogether. So we've probably taken all of the inflow. Dissections occurring now in front of the vena cava and behind the left hepatic vein, and ultimately the middle hepatic vein, which the left joins as a common trunk just before it inserts into the inferior vena cava. We can get the impression of that here and see the edge of that common trunk inserting into the cava there. So we're able to, using the laparoscope, pass safely in front of the vena cava and develop that plane very nicely. The superior attachments of the caudate lobe are now being divided, and that dissection's continuing further, again somewhat hampered by the replaced hepatic artery, but nonetheless we were able to preserve that. The view is a bit blurry here because it's bifocal vision. It was clear the other camera was working well, and now the camera's been cleaned and we get a much nicer view. We start to take that bridge of tissue over the front of the shunt now, just using the Thunderbeat as a dissector and vessel sealer. There are no major vessels running through here, although there is a small vein that requires attention with the bipolar. And care is being taken through the placement of that tape not to damage the underlying shunt. With that bridge taken, it's now possible to elevate the caudate in a different angle to approach its last attachments, where it's thinning out in front of the inferior vena cava. A few small vessels remain attached between the porta hepatis and the caudate lobe. Again, that artery being in the way is a little annoying, but we managed to work around it. The sucker's brought in now as there's a little bit of ooze, which is not unusual, but nothing major bleeding. The sucker can be quite a useful instrument as a retractor and a blunt dissector alongside a energy device such as the Thunderbeat. One can see that there's just a fairly thin bridge of tissue now running in front of the inferior vena cava, and once we continue the mobilization of the cava off the back of that bridge, we'll be able to take that bridge with a stapling device. the shunt's now fallen away from where we're working, making life a little bit easier since dividing that bridge. A small vessel is controlled, ties placed around it, and this facilitates the placement of a hemalock clip. There we go. And then the other side, because there's not much room, is taken with the Thunderbeat, sealing it off nicely. You'll note there's not been any formal dissection of the port hepatis itself, rather the whole operation, because it's for a suspected adenoma, has been up against the caudate lobe. Here we're back underneath the caudate lobe, really taking the last attachments back towards the porta hepatis. And here a stapler was used, even though it's not much of a pedicle there still may be a reasonable blood vessel inside this piece of tissue. The Raytec is of course pulled out of the way, and it's crucial at this point that no clips be caught inside the stapler, as that could cause a misfire of the stapler and lead to the knife firing without the staples working, which can be disastrous from a bleeding standpoint. A little capsule at the back of the caudate lobe is divided just to thin things out a bit more. You can see the inferior vena cava bouncing away at the back. That artery again annoyingly slung over. The parenchyma is really quite thin here. Fibrous structure is seen, may represent a small vessel, and therefore a hemalock clip's placed. And at that point the caudate lobe's been detached. The hepatic artery is still patent. There's a troublesome bleeding point on the parenchymal surface, which doesn't immediately get controlled, so we pack that away. While we place the specimen in a bag and remove that through a small Fannin steel incision. Now, after that phalansteal's been closed and the specimen's removed, we can come back and remove the packing around the raw surface and determine how to best control this annoying bleeding area. In the end, it was elected to suture it, as the precise bleeding point could not be picked up and clipped or controlled with bipolar diathermy. Suturing is difficult down this deep hole. Eventually, a couple of throws of the needle allow for the suture to be cinched down around the bleeding point. And while this little bit of blood looks dramatic, it's actually very little. Once that was done, things were relatively quiet from a bleeding point of view. A lot of irrigation is performed. A little bit of fibrillar is placed. This will be absorbed by the body ultimately, but helps with clot formation in the short term. You can see that the rest of the liver is not completely normal. Further fibrillar there up against the inferior vena cava, and then we have about a 3.5 hour operation condensed into something like half an hour. Through editing, the patient was discharged 4 days later and returned to see me after 3 weeks with healed wounds and a histopathology showing an adenoma with clear margins.